Sue Sheridan is a founding member of Patients for Patient Safety in the US and is currently the Director of Patient Engagement Emeritus for the Society to Improve Diagnosis in Medicine. She's a former advisor to the World Health Organization, WHO. In her role, she advocates for patients and works with healthcare systems and staff to improve diagnosis and safety for all patients. So Sue Sheridan, we would be delighted to hear from you. Thank you.
Thank you, Francis. And thank you for the opportunity to provide a patient perspective today and to channel the many others from Patients for Patient Safety US. It's really, truly an honor. So today I'm going to share my story when things went terribly wrong in the healthcare system to both my newborn son, Cal, and my late husband, Pat, to demonstrate the importance and urgency of patient safety as a major healthcare issue for PCAST. Next slide, please. I'd like you to introduce you to my son, Cal. He was born in 1995 in a large regional hospital. He was perfect, but then everything went wrong because of documentation errors, the lack of hospital policies, inadequate patient education, failure to follow evidence-based guidelines, and a culture that did not enable nurses to take action regarding newborn danger signs. Cal suffered brain damage when he was 5 days old, known as kernicterus, in my arms and before our eyes in the hospital. He never got the dollar test to determine if his bilirubin level was too high, but it was too late. Pat and I were crushed and alone. Our lives changed forever. No one would talk to us. There were no explanations or disclosure of what happened. There was no investigation. There were no reports to authorities. There was no place for me to report Cal's harm or share his data, despite my many attempts. There was no accountability and there was no learning. It was as though Cal's error and his harm were invisible. Next slide, please. About 2 years later, and soon after the birth of our daughter, Mackenzie, Pat also experienced a medical error when a malignant pathology of a tumor in his neck got lost in the healthcare system and never got communicated to the doctor or to us. Another classic diagnostic error. During the 6 months of non-treatment, the cancer metastasized throughout his spinal column, and they couldn't save his life. Pat died when he was 45, when Cal was 6 and Mackenzie was 4. There were no safeguards in place to ensure that a life-threatening document was communicated to the doctor and the patient. Honestly, it was a very dark time in my life. Next slide. But I want to share a silver lining to Cal's story about a group of moms who found each other, all whose newborns had suffered kernicterus just like Cal. And we formed a nonprofit called PIC, and we organized, managed, and led a patient-powered coalition. We were passionate, pushy, and impatient. The coalition included researchers, HHS agencies, accreditors, guideline developers, healthcare systems, patient safety experts, nursing and pediatric organizations, the AHA, and others. And together, we successfully changed the American Academy of Pediatrics newborn jaundice management guidelines to include a universal Billy test on all babies discharged from hospitals. We got kernicterus classified as an emerging public health issue at CDC, who then funded research and the development of a national parent education campaign. We successfully empowered nurses to take a bilirubin test without doctor's orders through actions at the Joint Commission. And we changed the standard of care in the United States and Canada. We were women on a mission. In what was considered an unconventional approach, we used our newborns' birthing data and stories to connect the dots for our healthcare system to put kernicterus on the radar and expedite the implementation of best practices. Interestingly, at the time that Cal was born, there were 0 reported cases of kernicterus in the United States because many cases before him were buried in data and in confidentiality clauses. Next slide. Given Cal and Pat's stories and many other stories, following are threats and recommendations for HHS agencies created by PFPS US that mirror very closely with the WHO's Global Patient Safety Action Plan. The threat number one, and maybe most importantly, and no offense to my colleagues, the current threat is that the current assumption in patient safety improvement is that the healthcare system can fix itself. That model hasn't worked. There is no urgency or warp speed mentality and behind solving patient safety. There are simply too many competing agendas. The recommendation is to democratize patient safety at all levels. We recommend HHS and all agencies to engage diverse patients, families, and communities, especially those who have been marginalized, in the design of the programming of patient safety to ensure that it is designed to be equitable, trustworthy, and patient-centered. Think about history. The life-saving changes in HIV and breast cancer were both driven by the patient community. Next slide. Threat number two is that no one is in charge. There is fractured federal leadership of patient safety. The recommendation is to establish greater national oversight and coordination of patient safety by having HHS establish an independent agency over patient safety, where patients and the public can report harms and threats to safety, such as the proposed National Patient Safety Board or other models, such as in the UK and Norway. Next is establish patient safety as a priority in the Secretary's national strategy and establish a federal advisory committee on patient safety and create a presidential commission for a patient safety moonshot. Next slide. Threat number three, we do not know the magnitude of harm. We don't have the right data to improve safety. There is a built-in tolerance of our oversight agencies regarding healthcare systems who do not report harm from unsafe care. Also, there's valuable data that's not shared because it's protected behind privileged and protective walls, such as in the patient safety organizations and in confidentiality agreements. How can we unleash this data? Recommendation: redesign reporting and surveillance of patient safety, of patient harm by having HRQ and CMS redesign the National Patient Surveys, HCAPS and CAPS, to include patient-reported experiences in safety. By having HHS develop mechanisms and platforms to capture patient safety event reports and related data. And by having CMS expand the list of reportable serious harms, including diagnostic errors, and require mandatory reporting of harms as part of the conditions of participation with appropriate penalties. By having the OIG expand the trigger tools to capture a wider variety of harms, as well as expand their surveillance beyond just the Medicare population. And by having CDC count how many people die from medical errors by including the option of medical error as a cause of death on death certificates to capture in the National Death Index. Next slide. Threat number four is truth-telling is optional when things go wrong. Obscuring the truth to patients and families and withholding patient data and notes after a harm has occurred has become entrenched in our system and accepted normalized behavior. The recommendation is to require standards for timely communication and disclosure to inform patients and families of a harm event, similar to those of candor laws in the United Kingdom and Australia, and programs here in the United States known as Communication and Resolution Programs, or CRPs. By having CMS require the implementation of a CRP or candor type program in healthcare systems as a condition of participation with meaningful financial penalties when there is no disclosure or learning. And by having ONC and CMS review and enforce the standards of the Cures Act with meaningful penalties that prevent information blocking, including patient access to medical records and notes. Next slide. Threat number five is the lack of adherence to evidence-based guidelines. The recommendation is that CMS require healthcare systems to implement evidence-based practices as a condition of participation, again, with meaningful monitoring incentives, and penalties to ensure adherence. Next slide, please. In conclusion, I want to go back to my family. We need to remember that we're talking about real people and not just statistics. Cal is now 27. He has significant cerebral palsy, is mobility impaired, hearing impaired, and speech impaired. Cal's very smart. He's caring, he's funny and courageous. He's an award-winning playwright and, believe it or not, a comedian, and perfect in his own way, but has lifetime challenges from events that never should have happened. I worry about him, but he's a warrior. Mackenzie, now 25, grew up in chaos and often in her own little world, trying to make sense of where her daddy went and why her brother was so different. She's an extremely compassionate and empathic person, is on a lifelong journey of healing. The toll on her emotional wellness has been significant. Eventually, she wants to pursue a career in helping others heal from trauma. I'm proud of her. Finally, going back to Pat, when he learned that he had about 10 days to live, he shared that he wanted to go to Disney World to watch his kids have the time of their lives. Within 4 days, 53 of us flew to Orlando, Florida, and Pat died at Disney on the 3rd day. But during those 3 days, we had precious conversations. And when we were talking about what I was going to do as a single mom, Pat said to me, whatever you do, do not give up on patient safety. So PCAST, I am here today because I fear that our country has given up on patient safety. We all need to be visionary, bold, and agree to revolutionize patient safety by redefining the roles of our agencies as well as the creation of new ones. And by redesigning patient safety with the passion, lived experience, and urgency that patients, families, and communities bring to the table. We all need to agree to do more, faster, to fight against unsafe care, just like we are currently treating climate change and biomedical and health research, so that we can leave behind a world in which healthcare is not harming people. So in honor of those who have died, those left disabled, our loved ones today, and the world's children yet to be born, we must all strive for excellence so that all involved in healthcare are as safe as possible, as soon as possible. Thank you.